Good day, dear great surgeon. Let's have some fun with the trauma and ER, and believe me, it's a lot of fun. Yes, your exam will be trauma and orthopedics as well as some anatomy. And the other chapter, you would wonder that they have a very minimal share in MRCS. But regarding the trauma, is the main pillar of the exam. It's not an orthopedic exam, but orthopedic overlaps with trauma in many aspects. So keep up and make trauma your language for MRCS and for real life. The ER surgeon is the best surgeon. So let's keep up and together we can. To crack the trauma, you have to be aware of the anatomy and some tricks like first to do and definitive treatment and the best management. Those are not the same. First to do is the next very step. The definitive management is the definitive treatment. It's not the same. It's the end stage of this process. Take care from those tracks. And regarding trauma in MRCS and in real life, we follow the ATLS protocol, Advanced Trauma Life Supporting Protocol, according to the 10th edition. And believe me, there are many updates in the 10th edition. And by the way, soon, by next year, there will be supposedly the 11th edition. Every 4 years, ATLS protocols are changing, and now we are following the 10th edition. So let's keep up together. This is great surgeon. From the very famous tracks in ATLS 10th edition changes protocol is the tension pneumothorax. It's now within the fast scan. So when ultrasound is available, tension pneumothorax can be diagnosed using an extended fast examination. So it's in the E-fast now. Previously, tension pneumothorax, there is no X-ray to do tension pneumothorax. It's a clinical diagnosis by the pneumotympanium, where you hear and tympani like tabla. So according to the ATLS 10th edition protocol, adult needle thoracocentesis now is within the fifth intercostal space, just anterior to the mid-axillary line, while in pediatrics it remains in the second intercostal space. So in adult, first to do for tension pneumothorax, fifth intercostal space thoracocentesis. In pediatrics, second intercostal space as before. This is the ATLS 10th edition protocol. I know most of you are with the old edition regarding that the adult in the second intercostal space. Welcome to the new era. Now, tension pneumothorax for adult in the fifth intercostal space. And by the way, finger thoracostomy is an alternative approach for emergency decompression for tension pneumothorax. But of course, the definitive treatment for pneumothorax will be a chest tube. Chest tube is the definitive management for hemothorax and pneumothorax. So an acute hemothorax that is large enough to appear on chest X-ray may be treated with 28 to 32 French gauge chest tube, because it previously was 36 to 40 recommended. Now 28 to 32 will be enough with the hemothorax manifesting on X-ray. Another trick in the 10th edition of the ATLS protocols regarding the musculoskeletal injuries, especially open fracture. They often appear dramatic and can potentially cause distract to the team members from more urgent resuscitation priorities. But can we use tourniquet for hemorrhage control? Let's see. Because of the potential life-threatening musculoskeletal injury can be detected during assessment of the circulation in the C ward, the team leader must rapidly direct the team to control the external hemorrhage using either stride pressure dressing, and this is a mainstay, or splint, or even tourniquet is appropriate in the 10th edition of the ATLS protocol. Now you have to be familiar that tourniquet is no longer prohibited in ATLS protocols. You can use tourniquet to stop bleeding, unlike any other previous ATLS protocols. So now you can use protocol of tourniquet. but with caution. To follow the ATLS protocol is to follow evidence-based medicine. There are many studies have been done to give us those protocols and frequently updating. So when we are talking about this protocol, it's not a Harry Potter spell or magic spell. It's an evidence-based science to control the situation. Another trick in the MRCS regarding the ATLS protocols. There will be no MRCS exam without a burn equation. And this is because the ATLS protocol for burn have been changing. Take care. We all use the Berkland formula for burn. And the Berkland formula was stating that 4 mg per kilogram per total body surface area burned. But take care. There is no more 4 mg per kilogram. 4 mg per kilogram is used only for electric burn. In adult, we use 2 mg per kilogram per total body surface area, while in pediatric, we use 3 mg per kilogram per total body surface area. And of course, the 50% of this fluid you calculate will be in the first 8 hours, and the rest of the 50% of this fluid you have calculated in the next 16 hours. So take care, it's not 4 mg per kilogram per total body surface area unless it's an electric burn. So in normal situation, the adult will be 2 mg per kilogram per total body surface area, and in pediatrics 3 mg per kilogram per total surface area. And of course, any burn is a trauma, you follow the APC. Another trick regarding the ATLS protocols, the tranexamic acid usage. According to the European and the American military studies, they demonstrated that the survival rate with usage of the tranexamic acid, which administered within 3 hours of injury when bolus fluid was given to the soldiers, improved the survival rate of the soldiers. So tranexamic acid is no longer not evidence-based. It's evidence-based and approved by the ATLS protocol. By the way, there is a moral concept you can learn from ATLS protocol, that the team leader is not necessarily the most senior person present, although he or she should be trained on ATLS. So the junior is like the senior in ATLS. The more important is the life saving, and the basics of the medical team management is the critical part. So it's no matter who leads, it matters who lives. The patient matter. This is the ATLS protocol. These great surgeons, when you face a hypovolemic shock patient in class 3 or class 4, which means he had lost approximately about from 30 to 40 or more than 40% of his blood, would you resuscitate this patient early with blood product or not? Guess what? According to the ATLS protocol, we give blood early as possible. So early resuscitation with blood and blood product must be considered in patients with evidence of class 3 and 4 hemorrhage, because early administration of blood products at a low ratio of packed RBCs to the plasma and platelets can prevent the development of coagulopathy or even thrombocytopenia. But take care, massive transfusion defined as more than 10 units of packed RBCs in 24 hours or more than 4 units in an hour. We don't mean to give a massive transfusion. We are advising to start the blood product to prevent the coagulopathy and thrombocytopenia. So the decision to activate the massive transfusion protocol should be made early to avoid the lethal triad of coagulopathy, hypothermia, and acidosis. The coagulopathy, hypothermia, and acidosis are the lethal triad. The lethal triad is more aggressive and more lethal, dramatic than the massive transfusion complication. But take care. In practice, the team must be aware of the amount of fluid and blood product have been administered, as well as the patient physiological response, and make necessary adjustment. And in practice, you have to catheterize the patient to follow up his urine output and his vitals. Those are your eyes on the patient and your guide. And that's why the team leader must ensure that a rapid intravenous access is obtained even in a challenging patient. Even intraosseous access, you can go for it in adult or children if there is no intravenous access can be obtained. And regarding the ATLS protocols, it's all about the ABC, airway, breathing, and circulation, where you do the EFAST and control every bleeding. Take care. Let's now focus on the lung injuries, like the pneumothorax. And please, don't confuse the management of pneumothorax due to trauma with the management of a spontaneous and complicated pneumothorax. For a rib fracture to cause a pneumothorax, there must also be a laceration to the underlying lung parenchyma. This has the risk of developing into tension pneumothorax, and therefore, this reason we have to put a chest drain as a definitive management. While thoracocentesis with a wide bore cannula in the fifth intercostal space in adult or in the second intercostal space in children, this is the mainstay first thing to do with pneumothorax, but the definitive treatment will be insertion of chest drain under water seal. Remember the lecture of the drains? We are talking here. The chest tube will be under water seal. So regarding the thoracic trauma, there are some key points you have to take care from, because less than of 10% of blunt chest trauma and 15% to 30% of the penetrating chest trauma requires operative intervention. So keep in mind. And now you can do EFAST and find the pneumothorax, because it was a crime to do a chest x-ray for pneumothorax. But regarding the medical legality, some countries didn't do chest tube or even thoracocentesis without a chest x-ray. So now pneumothorax is from your routine during the EFAST with the ATLS protocol. So do the EFAST, found pneumothorax, clinically you will find hyperresonant, go for wide bore cannula until you prepare your chest tube. Pneumothorax, it means air within the thorax cavity. Hemothorax means blood within the thorax cavity. Hemo, blood, pneumo, air. Remember that pneumopilia, this sign is characteristic for the gallstone ileus, where you find air within the biliary tree. This denoting that there is an air passed to the biliary tree due to a passage of a stone to the GIT lumens in the intestine and causing gallstone ileus. Remember the pneumopilia? Now we have pneumothorax, air in the thorax. So, what does hemopericardium mean? Hemopericardium means blood within the pericardium. So, a very famous question regarding a young age man who have been riding a motorcycle and did an accident. He have been fell off the motorcycle and will tell you those signs. He has distended neck veins, weak pulse, and the trachea is central. It's not shifted. So he is guiding you that this is not a lung injury. This is not a pneumothorax or other else in the lung. What is this? Of course, this is a hemopericardium. This is a cardiac tamponade produced by the hemopericardium. So the big triad in the question will be elevated venous pressure, reduced arterial pressure, and reduced heart sound or muffled heart sound. This is the big triad for cardiac tamponade, and there will be a pulsus paradoxicus. This can occur with a very little amount of blood, up to 100 milli blood only can cause cardiac tamponade, and this will be resolved by cardiosynthesis. So pericardiocentesis, the approach will be subxiphoid approach. This is the most common be used, where the needle is inserted between the xiphoid process and the lower costal margin at angle of 30 to 45 angle. The aim for the left mid clavicle, and direct needle toward anterior wall of the right ventricle and aspirate. Take care, because a flail chest can cause either tamponading or even pneumothorax. How can I differentiate between the tamponading and the pneumothorax? Simply, in pneumothorax, we have a classic presentation. This classic presentation will be including chest pain, dyspnea, hypoxia, hypotension, and tracheal deviation, and ipsilateral on the same side means ipsilateral hypercussion note, which is hyperresonant. It will be like a drum, طبلة حرفيا. So literally will be a drum. The lung, this side will be a drum, the pneumothorax. You can tap on it, it will be hyperresonant. There will be decreased air entry when you auscultate. And when you do EFAST, it will be founding there is no lung tissue in here. There is air. So don't confuse the tension pneumothorax with the Beck's triad of the cardiac tamponade. Cardiac tamponade has other manifestations. So don't confuse the Beck's triad with the tension pneumothorax. Beck's triad will have muffled heart sound, reduced jugular venous pressure, hypotension. So regarding the tension pneumothorax, a whole other thing. There will be a shift of the tracheal deviation. There will be a tension pneumothorax where you find the side of the chest will be drum, tympanic resonance, and dyspnea as well as hypoxia and hypotension. In the exam, he might ask you regarding the tension pneumothorax by the chest X-ray finding, so you have to be familiar with them. There will be a lung collapse towards the hilum, and it will be plaque, jet plaque appearance in the lung. This is a tension pneumothorax, and diaphragmatic depression increase rep separation. This is a tension pneumothorax, and increase thoracic volume, and there will be ipsilateral flattening of the heart border and the contralateral side mediastinal deviation. All of those are important chest X-ray features. So the immediate management of pneumothorax, immediate needle compression, and the best management will be chest tube, while the cardiac tamponade will be pericardiocentesis. Dearest great surgeon, take care. Aortic dissection is not the same as aortic rupture, because we have to be familiar that the aorta is made of 3 layers: the inner layer, tunica intima, and the middle layer, tunica media, and the outer layer, tunica adventitia. In the dissection, we are talking about the tunica intima, about the intima layer where the blood flows from the lumen of the aorta to in between the layers. But the rupture is the full cut of the whole 3 layers, the intima and media as well as the adventitia. Dearest great surgeon, take care. A man with a cardiac tamponading with raised CVB with hemodynamic compromisation, the definite management of this will be emergency thoracotomy in the theater. And since he has still cardiac output, the best option will be clamshell approach. This will give the best access to the cardiac and drain this hemopericardium in the cardiac tamponading. If there is a significant delay of the operation, this may consider pericardiocentesis until we reach no delay. However, this is not a widely practiced option and go for thoracotomy in the theater. Please, great surgeon, take care. Flail chest is not like any other tear. Multiple rib fractures with more than 2 rib fracture in more than 2 reps is diagnosed as flail chest. It can be associated with pulmonary contusions. It can lead to pneumothorax or even cardiac tamponading. But take care from the term. You might have been asked about the term itself, flail chest injury. It's a multiple rib fracture of more than 2 rib fracture in more than 2 reps. Be scientific in your practice and your exam. Flail chest. So, flail chest, where the chest wall disconnects from the thoracic cage, with multiple rib fractures, at least 2 fractures per rib in at least 2 reps. So it can be associated with pulmonary contusions or even abnormal chest motions, and avoid overhydration and fluid overload with flail chest. Another trick regarding the flail chest, that the management of the flail chest just like the simple rib fracture by plastering and immobilization of the rib and fixation with a plaster with no intervention or no operative. But if the patient is desaturating and took his pain medication, pain management for the rib fracture like bupivacaine injection, so go for intercostal chest tube because the patient is desaturating and oxygenated and having his pain management. But first, the flail rib management will be Pivocaine injection and giving him support, chest support with the chest garment, just like the simple rib fracture. But if the patient is desaturating over his already taking the pain medication, give him intercostal chest tube to save the patient life. We surgeons are familiar with the tension pneumothorax or even the pneumothorax or now the flail chest. All are traumatic causes. But an old man who is drunk came to you to the ER and said to you, "Oh, doctor, I have been coughing all the night and now I have a crepitus chest and epigastric region is pain me and feeling a burn sensation. What is this, doctor? And you say to him, "Go, old man, you are such a drunk, go home." And this man will go home and die in peace. Take care. This patient is esophageal perforation patient. Came to you with the macular triad of Borhave syndrome with vomiting, thoracic pain, and subcutaneous emphysema. Don't judge the people because they are drunk. I know being drunk is not good at all and may affect your liver as a doctor. But take care, we are doctors. We are here to heal the patient. The patient came to you with the macular triad of Borhave syndrome, vomiting, thoracic pain, subcutaneous emphysema, which presented with the mild crepitation in the epigastric region. Don't miss the esophageal perforation. It typically presents in the middle-aged man with a background of alcohol abuse. You have to differentiate between the Borhave syndrome and the Miller-Weiss. Miller-Weiss is only a partial spontaneous rupture in the esophagus, but the Borhave is more serious than the Miller-Weiss. The Miller-Weiss is spontaneous rupture in the esophagus that occurs as a result of episodes of repeated vomiting. By the way, the Borhave syndrome rupture is usually distally sited on the left side of the esophagus, and patients usually give history of sudden onset of severe chest pain that might confuse you with myocardial infarction if you keep it in mind, or even aortic dissection. But take care, there will be no hypovolemic shock, so think of the Borhave syndrome of this patient with mediastinitis. There will be severe sepsis occur secondary to mediastinitis, and the diagnosis is CT contrast swallow. The treatment is with thoracotomy and lavage if the patient presenting with you in less than 12 hours of the onset. Then the primary repair is usually feasible and available for this patient. So please save this patient when he came to you with the macular triad and don't judge the patient. While if you forget the patient and the patient didn't come to you within 12 hours, so we have to be best managing the patient with insertion of a T-tube to create a controlled fistula between the esophagus and the skin. And any delay beyond 24 hours are associated with very high mortality rate. So again, don't judge the patient. Listen to the patient complain carefully. Don't overwhelm and never underestimate. Dr. Muhannad saying that the patient will not die peaceful death. Believe me, he will go home and say, "It's me. I might have been drunk. I don't know more than the doctor. The doctor is good and will die. Yes, I have pain and I will sleep in my pain and will not have any mourning." So please take care of your patient. And of course, the feeding for Borhave syndrome will be TPN, and you have to use a water-soluble contrast while using the CT contrast swallow diagnosis. Take care. We talked about the Borhave syndrome and rupture esophagus. How about the perforated peptic ulcer? Take care. The perforated peptic ulcer, the patient will come to you with board rigidity and there will be epigastric pain. The epigastric pain is very important differential in your clinical life. It might be myocardial infarction. It might be pancreatitis. It might be even Borhave syndrome as we have discussed, or even if shifted to the right hypochondrium, it might be acute cholecystitis, or even just gastric peptitis. So take care. Medicine is incidence, medicine is science. So examine your patient and never underestimate your patient. Search for the cause of the pain. Perforated peptic ulcer. The patient will usually develop a sudden onset of epigastric abdominal pain. He will be either a smoker or on alcohol or even a non-steroidal. The most common cause will be non-steroidals. It may be soon followed by generalized abdominal pain. It will be a board-like rigidity abdomen. This is perforated peptic ulcer for sure, because the whole gastric juice became in the stomach, caused peritonitis. Severe peritonitis causes spasm of the muscle, causes board-like rigidity. So there will be features of antecedent abdominal discomfort. The pain of the gastric ulcer is typically worse immediately after eating. And diagnosis made by erect chest X-ray. You will find a rim above the liver. There is no air under diaphragm. The liver is below the diaphragm on the right side. But in perforated peptic ulcer, there will be a rim, air under diaphragm. This is a perforated viscous, and most commonly to be peptic ulcer. So not every air under diaphragm a perforated peptic ulcer, but every viscous might be peptic ulcer. Every perforated viscous will cause air under diaphragm. Even a perforated appendix can cause air under diaphragm. Any patient going through exploration can cause air under diaphragm. But medicine is incidence. The most common to cause air under diaphragm is perforated peptic ulcer, especially when the patient comes to you with sudden onset of board-like rigidity and giving you the history of having a non-steroidal or a heavy smoker patient. Of course, the management of perforated peptic ulcer is surgery. Go for laparotomy and give him an omental patch, Graham's omental patch. It can be done laparoscopy or via laparotomy. Whatever technique you can use will be the answer. Of course, perforated peptic ulcer, the patient will come to you in severe sepsis. Please resuscitate the patient. We are not treating an ulcer, we are treating a patient. Go for APC, resuscitate the patient and prepare him for emergent operation. As we mentioned, the epigastric pain, it can be pancreatitis. Remember, pancreatitis, the patient will come to you relieved by leaning forward. If he leaned forward, as if he is praying forward or giving you a greeting, he's not greeting you. No, he is just in pain and making himself relieved. This is pancreatitis. And this sign leads us to remember that our doctors during our clinical sessions always said to us what is the decubitus of the patient. So the decubitus and the position of the patient important for this. If the patient is leaning forward and he is having epigastric pain, you have to differentiate the pancreatitis. And in all the patient, you have excluded Borhave, you have excluded perforated peptic ulcer, you have excluded pancreatitis, and there is no elevation in the amylase, neither the lipase, and there is no gallstone, and there is no history of non-steroidal. This patient might be a myocardial infarction, and literally the patient will die in peace if he go home. Do this patient ECG, please. So myocardial infarction is a very important differential diagnosis for epigastric pain. If you didn't find any other differential and the scenario by the history doesn't go with any other differential, the patient will come to you traditionally describing a sudden onset of central crushing chest pain he didn't experience before. It might radiate into the neck and down to the left arm. The signs are autonomic dysfunction may be present, and the presenting feature may be atypical in elderly or those with diabetes. Diabetes is a mean disease which may mask even myocardial infarction and will give him a peaceful death without going either to the hospital. So the diagnosis is made by ECG. An ECG can save a life. Please do this patient an ECG. You are a surgeon, but keep it in your mind. And by the way, if you have excluded all of this, and ask your ER doctor, did he do a random blood sugar If you didn't find myocardial infarction or any of other differential we talked about, this doctor made the patient and random blood sugar, he might be in DKA. DKA can cause epigastric pain and full board-like rigidity and gastric pain and colic pain. Might be DKA. Keep all of those differentials in mind, but keep them like a tree. And when you are following ABC in your ER, you will be a king. So regarding the myocardial infarction, the treatment will be oral antiplatelet agent and primary coronary angioplasty and thrombolysis might be beneficial. And of course, there will be changes in lead 2, 3, and AVF for the inferior leads from V1 to V5 for the anterior leads. Don't confuse the pulmonary embolism manifestation with any other disease you know, because pulmonary embolism will typically be a sudden onset of chest pain. We are not talking about epigastric pain. In some cases, it might come by epigastric pain, but commonly to be a chest pain because it's mainly a chest disease. So, and the manifestation will be hemoptysis, hypoxia, and the small pleural effusion. Take care. Most of the patient will have an underlying deep venous thrombosis. That's why if the patient having DVT, we are not feeling from the DVT in the limb itself only, but the showering which can be caused by the deep venous thrombosis, which can cause a pulmonary embolism. The diagnosis might be suggested by ECG, where there is a changes in the ECG like including S wave in lead 1 or Q wave in lead 3 and inverted T wave in lead 3 confirmation, and the best diagnosis will be CT pulmonary angio, CT pulmonary angio, which is CTPA as you all know. CT pulmonary angio is the best investigation for pulmonary embolism, and of course the treatment will be anticoagulation in those patients who develop cardiac arrest or severe compromisation, or it might pass silently, by the way. But take care, you have to follow and know pulmonary embolism, including which wedge in the CT. So a very famous scenario in the exam will come to you: an old patient with chest pain is going to have elective surgery like hip replacement, for example. And by the way, he had been in bed for 3 months. He is bedridden. He is guiding you that might be having a DVT or stagnation of blood, and suddenly the patient collapses, and the blood pressure 70 over 40 millimeter mercury, and the blood rate is 120, and his saturation is desaturating about 74% on room air. He is deteriorating. What is the next best management plan? This man is very arrest with diagnosis of pulmonary embolism because he is having chest pain, he is bedbound, he is collapsing with desaturation, low saturation, or room air. This needs urgent thrombolysis with alteplase. He might not survive if you wait for medical to arrive. Give this patient thrombolysis with alteplase. So in massive pulmonary embolism, CT pulmonary angio or echocardiography will be reliably diagnostic for clinically massive pulmonary embolism, and thrombolysis is the first line for massive pulmonary embolism, including circulatory failure, and may be instituted on clinical ground alone if cardiac arrest is imminent. A 50 milligram bolus of alteplase is recommended. And by the way, invasive approach like thrombus fragmentation and IVC filter insertion should be considered where the facilities and expertise are readily available with massive pulmonary embolism. Let's see the British summary for Thoracic Society guidelines for pulmonary embolism management. The pulmonary embolism management, according to the Thoracic Society guidelines, that heparin should be given if intermediate or high clinical probability before imaging to save this patient's life, while unfractionated heparin should be considered as a first dose bolus in massive pulmonary embolism. And take care, where rapid reversal of effect might be needed, give him unfractionated heparin. Otherwise, Low molecular weight heparin should be considered as preferable to unfractionated heparin. So, if rapid reversal is required, give the patient unfractionated heparin. When there is no need for this, give a low molecular weight heparin and should be considered preferable to the unfractionated because it have equal efficiency, safety, and being easier to use. Oral anticoagulant should only be commenced once the venous thromboembolism has been reliably confirmed, and the target INR should be from 2 to 3. Again, you are targeting to reach with the patient the INR to be 2 and 3. When this is achieved, heparin can be stopped here. And the standard duration of oral anticoagulation like warfarin is about from 4 to 6 weeks for temporary risk factors, and 3 months for the first idiopathic, and 6 months for any other reason. The risk of bleeding should be balanced with that there is no further venous thromboembolism occur. So don't confuse the pulmonary embolism with the massive pulmonary embolism. The first line for the massive pulmonary embolism will be ATLS, while the normal pulmonary embolism, which is moderate intermediate, give him or high suspicion, high probability. We are talking about giving the patient unfractionated heparin if you are considering a reversal, or low molecular weight heparin if you are not considering a reversal. But the massive pulmonary embolism, give him altilibase. Hope this make it clear. By the way, after operation, the patient is tachypnic and desaturating and having a pink rash over her chest. This patient might have a fat embolism. Take care. Keep it in mind, especially after liposuction or fat injection with the plastic surgeon. May God save us all from this complication, but it might occur and have to keep it in mind, because if you know it, you can deal with it. Dear great surgeon, so happy to have been with you those 2 hours, and thank God that every day at this time, which is unusual to be free by 2 p.m., most my times are free at 7 a.m., but I'm so happy and so glad to have been with you those times, and may God keep us gathered all time, all along. I want to advise you something.